Okay, so there we go. Hopefully those case studies that we went over really helped solidify your understanding of electrolyte imbalances a little better, and really just like looking up the signs and symptoms of some of the imbalances and the history and physical as well. So before we drop back into acid-base balance, I did want to just briefly mention the urine osmolality. Or not the urine osmolality, but rather the specific gravity, because it was a concept that came up. So hopefully, sounds like you guys did research on this during the assignment, and I'm hoping you did. So what is the specific gravity?
Weight of particular fluid versus water.
Good. So really, all it is it's a ratio that compares the density, right? Yeah, the density of urine to the density of water. So normally the urine is going to be a little more dense than water, right? Because it's going to have some stuff, more solute in it than pure water, right? And what is the normal specific gravity? 1.0102.
1.013.
Good, 0.13, all right? And water would be 1, right? So is water going to be over here or over here?
To the left.
Yeah, so water is going to be over here by 1, right? Does that make sense? So what we're saying is that specific gravity is less than 1.010 indicate that you have very dilute urine. Does that make sense? You guys good there? And then specific gravity is greater than 0.013 means that the urine is going to be more concentrated. All right, so if your urine is very dilute, what does that mean? You're getting rid of free water, right? Your body is attempting to get rid of free water. And then if your urine is very concentrated, what does that mean?
Dehydrated.
Often it means that you are dehydrated, or you lack free water. So in that case of the patient, the nausea and the swollen tongue and the altered mental status, and that patient was hypernatremic, right? And so I think that was the one that asked about the specific gravity of the urine. Oh, yeah, that's right. The nauseated lady was drinking all the ginger ale for a couple of days, right? So this was a lady who's holding down fluids, but very hypotonic fluids, right? And so the question is, do you think that her urine is going to be very concentrated or very dilute? Probably very dilute, so it'd be less than 1.010. Does that make sense? She's got too much free water on board. And that makes sense given her labs, right? Her sodium was a little low, right? And that kind of makes sense. You've got a dilutional hyponatremia, or if you follow the little algorithm that we went through last week, that would be an isotonic, right? That would fall more into the normal volemic or isotonic kind of, or not isotonic, but normal volemic. Her volume's normal, right? She's got good volume, but it's that the sodium that she has is being diluted due to all the free water, the excess of free water. Okay, so that's a concept of specific gravity, specifically urine-specific gravity. And I think that's good as far as all of the other case studies go. You guys have to do. I'll look at those case studies and get grades out to you all. Okay, so what I want to do now is go back to acid-base balance. and go beyond just calling something a metabolic or respiratory acidosis or alkalosis, and we want to talk about compensation now. And the rule of thumb for compensation is the body will never overcompensate, okay? The body never overcompensates, so remember that. It's easy to trick yourself into thinking that there's some compensation going on that really isn't. All right, and so there are 3 different types of compensation. Either the body will not compensate at all, we call that an uncompensated problem. The body will try to compensate, but it just won't get the job done. That's what we call partially compensated. And then the body can compensate for that acid-base imbalance, and that's what we call compensated or fully compensated. And that can either be acidosis or alkalosis, and it can be metabolic or respiratory. So what we want to do is we want to identify the primary problem. Okay, what is my primary problem? All right, is my primary problem one of acidosis or alkalosis? All right, and that's why we always want to look at the pH first. All right, so let's do this here. pH, PaCO2, HCO3 are the 3 main things we're going to look at. So, let's look at this gas here. So let's look at the pH first of all. pH, is it acid, base, acid normal, base normal? Acid. You guys okay with that? And just remember the pH is 7.35, 7.45. 7.4 is totally normal, right? And then 4.1 to 4.5 is what we would say base normal. And 3.9 to 3.5 is acid normal. And then less than 7.35 is acid, and greater than 7.45 is base. You guys good with that, or alkalosis? Okay. So this is clearly outside of 7.35. So this is full on acid. All right. So the primary problem is acidosis, right? So now we got to ask, well, what's causing the acidosis? Well, let's check the respiratory system. Is it high, low, or normal?
High.
Remember Rome, a high CO2 correlates with a low pH. So that makes this acid. Let's look at the bicarb, acid, base, or normal? Normal. Okay. So what is the cause of the problem?
Respiratory.
Would you all agree that this is respiratory acidosis, right? I'm going to connect the dots. So this is a respiratory acidosis. And now we just need to answer the last question. Is there compensation or is there not compensation? So here's how compensation works. Once you identify the problem and who's causing the problem, and we've done that, right? Then you need to ask yourself, is the other part of the equation, is it stepping in to help? Is it stepping in to help out?
So we're asking if the other part of the equation is abnormal?
Right, so what we're asking is, if my problem is a respiratory acidosis, is the metabolic component trying to compensate for that? Does that make sense?
Right.
That's what compensation is.
But how would you tell? Because it would be an abnormal lab?
Yeah, so how we tell is we look at the other component. You guys see that there. And what is that bicarb? Is it acid, base, or normal?
Normal.
It's normal. And so a normal value means no compensation. That means that the metabolic system is not compensating. Does that make sense? So in this instance, we would call this an uncompensated respiratory acidosis. Do you guys see how we got there? Okay, so what I'm gonna do is I'm gonna put up another ABG here. Okay. So here we go, pH 7.28, CO2 52, bicarb 29. So let's look at the pH. Acid, acid normal, base, base normal, acid, or base? Acid, you all see that there? So, acid. Okay, and so we've got a problem. What's causing that problem? Let's go down. CO2, acid, base, or normal? Acid. Bicarb, acid, base, or normal? Acid, base, or normal? It's base, right? Remember Rome, respiratory opposite, metabolic equal. So high bicarb is base, right? You guys good with that? So the pH is acid, the CO2 is acid, and the bicarb is base. You guys see that? Okay. It's base, and base means the same thing as alkalotic, right? So what's the problem though? Respiratory acidosis, because the pH, right? The pH is the problem, and then respiratory metabolic are the causes, right? So, we will call this a respiratory acidosis. You guys see that okay? And then the next question is there compensation? Is the other component moving to try to correct that? Yes. If my problem is acidosis and it's caused by the respiratory system, right, and the metabolic component is becoming more basic, then it is trying to compensate. Does that make sense? So to answer the question, yes, there's compensation. You guys agree? Now the next question is, what kind of compensation? There are only two types. There's partially compensated and fully compensated. Uncompensated would be none at all, right? So, what tells us the difference between partial and fully compensated? Well, if this was fully compensated, where would the pH be? It'd be in the normal range. It would not be normal, it would be in the normal range. Does that make sense? So, is this fully compensated? No. So it has to be what? It has to be partially compensated. So this is partially compensated respiratory acidosis. Do you guys see that there? Okay, let's do one more here. So let's look at the pH. Acid, acid normal, base, base normal, acid or normal? Would you guys agree that this is acid normal? Okay, this is acid normal. Okay. So there may or may not be a problem, right? There may or may not. So let's see if there is. CO2, acid, base, or normal? It's acid, right? It's greater than 50 or 45. Bicarb, acid, base, or normal?
Base.
Base. Okay. So what's my problem? My problem is there a problem? Yeah. What is it? Okay, what's causing it? Okay, so this is a respiratory acidosis, right? You guys agree? A respiratory acidosis. And is there compensation? Yes, this is the metabolic components attempting to compensate. And is it getting the job done? The pH is in the normal range, right? But in the acid normal range, right? Does that make sense? So because this was able to get the pH shifted into the normal range, albeit on the acid side of normal, it was able to fully compensate. Does that make sense? So we would call this a compensated respiratory acidosis. So I have 3 examples with values that are more or less the same. I have an uncompensated respiratory acidosis, and you can clearly see the bicarb has not attempted to compensate at all, right? I have a partially compensated where the bicarb increased, but the pH was still outside of the acid normal range. And then I have a fully compensated where the pH is in the acid normal range, but the CO2 is high, and so the metabolic component was able to overcome that. Does that make sense? So I have 3 examples of that. So when we talk about the body compensating for acid-base problems, right, there are what we call buffer systems within the body. All right, buffer systems. And these buffer systems are designed, they have evolved to prevent sudden pH changes in your blood plasma, right? And there are really 3 major or primary systems that you need to be aware of. The first system is the most rapid acting system. All right? So if there's acid that's being produced and it's releasing hydrogen ions, okay, those hydrogen ions will be buffered by this system almost immediately, right? This system begins to act within seconds, but it's easily overwhelmed. And this is known as the bicarbonate buffer system. All right, you have a bunch of bicarbonate floating around your blood, and it's actually at about a 20 bicarbonate molecules to 1 hydrogen ion, a 20 to 1 ratio, right? And as soon as you have more acid than you have bicarb, then your pH will begin to change, right? So this system begins acting within seconds to minutes, but it's easily overwhelmed, right? I can hold my breath, and I can start feeling the effects very quickly, because how long can most of us hold our breath? Not very long, maybe a minute, right? Maybe a minute if you're lucky, but what happens within about 10 to 15 seconds holding your breath? You start feeling like you got to take a breath. Right? What's happening? That carbon dioxide that's being produced by your tissues is being converted to carbonic acid, and right, initially what happens when you hold your breath is it's able to buffer that, and then as more and more carbonic acid is produced, more hydrogen ions are released, the pH of your blood is decreasing, right, and the bicarbonate buffer system begins to fail, and then you begin to go, oh my God, I need to take a breath now. Make sense? Right?
20 to 1 ratio is what?
20 bicarbonate to 1 hydrogen ion. Yeah. Okay, so that's a first system. The next system takes minutes to hours. All right. It takes minutes to hours to compensate. And it is the respiratory system, your lungs, right? If you become acidotic, right, your lungs can do what in response to that acid buildup? Your respiratory system can do what?
Increase breathing.
Increase the rate and depth of breathing, right? And you can blow off carbon dioxide, right? You might not be able to get rid of whatever the acid is that's causing the problem, but you can get rid of carbon dioxide, right? And so sometimes we say there are 2 kinds of acids in the body. There are what we call fixed acids and volatile acids. And fixed acids are acids that cannot be eliminated by the respiratory system. So like hydrochloric acid, hydrofluoric acid, right? Some of those, they're fixed, right? You're not going to get rid of them. But the volatile acids like carbon dioxide, you can get rid through your lungs, right? You can exhale those. Good. And then the third major buffer system is the definitive system. This is the definitive system for acid-base balance, but it takes a long time. It can take hours to days. And these are your kidneys. The kidneys can either get rid of bicarbonate or hold on to bicarbonate, or get rid of hydrogen ions or hold on to hydrogen ions. They are kind of the definitive way of dealing with acid-base imbalances. So when we look at these arterial blood gases, not only can we identify problems and compensation, but they also give us an idea of where somebody is at in their disease process. For example, if I look at this ABG here, this was an uncompensated respiratory acidosis, right? Is this early or late in the disease process? This is early, right? If it was late in the disease process, right? Because if the bicarb, it's going to take hours to days for that bicarb to change, right? Because of the kidneys. Does that make sense? So we know that this is early into the disease, whatever problem is causing this, it's fairly early, right? And then if we go down here with partially compensated, this suggests what? That we're a little later in. And then the fully compensated suggests that we're days into whatever this disease is, right? So this is probably more chronic here, right? Whereas partially compensated and uncompensated tend to be more acute problems. Does that make sense? How that works, right? So we can also tell acute kind of from chronic problems as well. You guys good with that? Okay. So let's just work through some more examples. I'll just throw some more examples up here, and we'll just work through several of them. Okay, let's look at this one here. So pH is 7.47. Acid, base, normal, base, normal. Base, you guys see that? It's clearly outside. So this is base or alkalosis. CO2, acid, base, normal. Come on, Rome, right? Low CO2, right? So this is base. Bicarb. Acid, base, or normal? Remember Rome. What's the normal bicarb again?
22 to 26.
22 to 26, right?
Acid.
Acid, right? It's less than 22, right? So this is acid. What's the problem? What's the primary problem? Right? My problem's always going to be pH, right? Both of these are abnormal, but only one of them is causing the problem, right? So my problem is always going to be my pH. That's why we start at pH, right? pH is abnormal, it's basic. So my problem has to be something that causes alkalosis, right? What connects the dots here? Good. So the primary problem is a respiratory alkalosis. You guys good there? Respiratory alkalosis. And then the next question is there compensation?
Yes.
There is compensation. This is acidic, right? But is it getting the job done?
No.
No. So it's No, it's
Partially.
trying to, it's partially compensated, good. So this is
So, does it work the other way around, like, say
Partially
if it's a metabolic problem, then the respiratory will try to compensate?
absolutely, absolutely. Okay. pH, acid, base, normal, acid, normal, base, normal. Acid, everyone agree? Okay, CO2, acid, base, or normal?
Base.
Base. Bicarbonate, acid, base, or normal? Acid, all right. So, what's the problem? Acidosis, what's causing it? Metabolic, right? So I have in this case, I have a metabolic acidosis. And is there compensation? There is, right? The CO2 has decreased, become more basic in response to the acidosis. Is it getting the job totally done? It's trying to. So if it's trying but not, we call that partial compensation. So this is a partially compensated metabolic acidosis. Was that an example of maybe some? You guys go with that? Do you just want to keep working through a couple more examples? Yeah, let's do that. Let's do that.
So the last one with the CO2 being, so there would be, it would be less CO2, right, that they're breathing off? Or less, well, because CO2 is essentially the acid, right?
It is an acid. Mm-hmm.
And so you said it was base, right?
So they were blowing off CO2, right?
Right,
In response to the metabolic acid.
right.
So let's take a look at this one here.
That's why you need to put in tidal
Let's see. Okay, let's look at this one here. So what's my pH? Acid, base, normal, base, normal.
Base. Or base normal?
Base normal, right? It's in the base, the range there? Okay. So this is base normal, which means there may or may not be a problem. Let's go digging. So CO2, acid, base, or normal?
Acid.
Acid, base, or normal?
Acid.
base.
Come on, guys. Write down Rome.
I got it right here.
Write down Rome.
Let's compare opposite metabolic.
Okay. So is this acid, base, or normal?
This is base.
This is base, right? It's less than 35.
I got backwards.
I was looking at
Remember, carbon dioxide is an acid. It's not a literal acid, but it's converted to an acid, right? You need to look at CO2 as an acid, right? Think of this like it is an acid. So a low CO2 is going to be a high pH, right? Right? A high CO2 is going to be more acid, lower pH, right? So is this acid, is this base, or is this normal? This is base, right? You guys good with that? This is base. Acid, base, or normal on the bicarbonate? Acid. Okay. So what's my problem? I do have a problem, right? What's causing it? Good. So the bases line up. See how I draw the arrow every single time? Right? I draw the arrow to the base to tell me that my primary problem is a respiratory alkalosis, right? My CO2 is basic and my pH is in the base range of normal. It's normal, but it's in the base normal. Does that make sense? All right. So I have a respiratory alkalosis in this case. And then I just need to ask myself, is there compensation? Is the body trying to compensate? Yeah. Because this is becoming more acidic, right? It is moving opposite to what the problem is. But is it getting the job done? It is, right? So we would call this what? Compensated respiratory alkalosis. Yeah. You guys see that there? Okay. All right. So far, so good?
Yeah.
All right. So let's just up the ante a little bit more and start making this clinically relevant now. All right. So let's do this. I'm going to give you a gas, and then I'm going to give a few conditions, some pathologies that could be causing that gas. All right, so here's our patient. This is their ABG. And let's do that. And then condition A is going to be a COPD exacerbation. Condition B is going to be an asthma. An asthma attack. Condition C is going to be an opioid overdose. Condition C is going to be pain. And then E is going to be fever. Okay. So let's just say that gas has to be caused by one of those. So let's take a look at the gas. What are we dealing with here? pH, acid, base, normal, acid, normal, base, normal?
Acid.
It's full on acid. CO2, acid, base, or normal?
Acid.
Acid. Bicarb, acid, base, or normal? Normal. All right, so what's my problem? A respiratory acidosis, is there compensation? No compensation, that's what the normal N and U are. Okay, so this is an uncompensated respiratory acidosis. Would you guys agree?
Yes.
That's what we're dealing with. So are we dealing with an acute or chronic problem here? Probably pretty acute, right? Because there's no compensation at all, right? Does that make sense?
Yeah.
There has not been enough time to compensate, so this is at least something that is less than days old, right? It's fairly acute. All right, so with that in mind, let's look at these. Let's look at fever. What would you expect fever to cause? Acidosis? I'm not adding anything here. I'm just saying fever. We have fever. I'm not saying septic shock and all. I'm saying fever. But what happens when you get fever?
Body temp rises.
Your temperature rises. What happens to your heart rate? What happens to your respiratory rate? You breathe faster and deeper, right? If I'm breathing faster and deeper, what am I doing? Blowing off CO2. I'm becoming more alcohol. I'm developing respiratory alkalosis. Is that what we see here? No. So fever, right? Fever would be more apt to cause a respiratory alkalosis. So could we eliminate fever? Yes. Let's look at pain.
I would say the same thing.
Pretty much the same thing, right? Pain is going to cause an increase in respiratory rate. That's also going to cause a respiratory alkalosis, so we could also get rid of that. Let's go up to COPD exacerbation. So if I have a COPD exacerbation, what's happening? Good, I'm having a problem getting rid of air, right? That's going to be more respiratory acidosis. Oh, look at that. But it's uncompensated. COPD patients, well, they have a chronic disease, right? So we would expect some sort of compensation, right? We don't see any compensation here, so this is not likely to be a COPD patient, is it? All right. So asthma attack. Could this be an asthma attack?
I'd say it could be because you're not really oxygenating, or I mean,
We-
ventilating. right?
Yeah, we don't know the oxygen, I
Yeah,
didn't include that.
Ventilation, so.
But with asthma, you're bringing in up, but you're not able to blow it off, right? So-
Right, so
So it's gonna be roughly the same.
as a COPD,
COPD.
yes. Except, can asthma be acute?
Yes.
Yes.
It can. So this might be an asthma attack, huh? It might be an asthma attack. Let's look at opioid overdose. So if I overdose on opioid, what's gonna happen?
Respiratory distress.
Huh? Respiratory depression, right? I'm gonna stop breathing. And if I stop breathing, or I'm hypoventilating, what's gonna happen? I'm not gonna blow off CO2. I'm gonna get acidotic. And do opioid overdoses tend to happen very slowly or very quickly? Pretty quick, right? You overdose, your breathing slows down, and this is something that happens within minutes, right? Oh, this is, right? So, between asthma attack and opioid overdose, which one of these two do you think would be best represented by this arterial blood gas? Probably opioid overdose, right? Because will the opioid overdose cause respiratory acidosis? Yes. Will it happen very quickly? Yes. So there'll be no compensation. And so this is in fact a kind of ABG that you would expect to see with an opioid overdose, an uncompensated respiratory acidosis.
So both those things can happen with asthma too.
They can, but with asthma, you tend to actually, initially you will develop a respiratory alkalosis. So initially what happens when you first have the asthma attack, you start feeling, right, it's coming on, and you start breathing faster and deeper, and you'll actually see a respiratory alkalosis, and then as you begin retaining, then you see a respiratory acidosis, right? So between those two, this is probably best represented here, right? Opioid overdose is probably best represented as an uncompensated respiratory acidosis. You guys okay with that? But you're absolutely right, it also could be an asthma attack as well. Does that make sense though? Okay, good. Good. So let's do this here. Let me give you another ABG. Okay. And let's talk about conditions. Okay. So here are some potential causes. Here's the ABG. Let's interpret it. So take a look at the pH. Acid, base, normal, acid, normal, base, normal.
Acid normal.
So this is an acid normal, which means there may or may not be a problem. So let's move on. Let's see if there is a cause. Respiratory, acid, base, or normal?
Acid.
Acid. Okay, bicarb, acid, base, or normal? Let me do this instead. Let's do this instead. 20. I'll give you 20. Base. Okay. Good. So what's the problem?
Respiratory acidosis.
Respiratory acid. You guys agree? Is there compensation?
Yes.
What kind of compensation? Is it partial or full?
Full.
It's in the normal range.
So it has to be fully compensated. Yeah. Yeah. So this is a compensated respiratory acidosis. Okay. Okay, so let's look at the potential causes. Asthma attack. Well,
No, because it's acute. Right?
good, because asthma attacks tend to be more acute, right? So yeah, you could have an elevated CO2, but it takes, again, hours, really to days for the bicarb to rise, right? So this is less likely to be an asthma attack. What about pain? Pain would tend to cause an acute respiratory alkalosis, right? What about an opioid overdose?
Like before, but it would be uncompensated.
Good, it would be a more uncompensated versus a compensated respiratory acidosis. What about COPD exacerbation?
That would be a compensated.
It could be.
But when you say, like, where does it partially compensate, because you pushed it past your limit?
There you go, you're definitely on the right track. So with COPD patients, right, and this other one is COPD patient without complaints, right?
Right.
So it's really between an exacerbation without complaints. Which of these is most likely represented by this ABG here?
Without complaining.
Without complaints. So this is a kind of a classic ABG that we see in COPD patients who are stable, right? Their disease is under control. Is they are compensated, right? They always have some underlying respiratory acidosis, but their metabolic component has been able to compensate for it, and they're feeling okay. And then when they get sick and they exacerbate, this compensated respiratory acidosis becomes a partially compensated respiratory acidosis. Does that make sense? So a partially compensated respiratory acidosis in a COPD patient is indicative of a COPD exacerbation, whereas a fully compensated ABG may very well be normal for that person. Does that kind of make sense there? You guys okay with that?
Well, in terms of, like, say, capnography,
Mm-hmm.
we're going to see that distinct difference on their entitled CO2.
Yes, their entitled CO2 is going to be higher than normal. Yeah, absolutely. Unfortunately, we might not have a blood gas to back up, right, and to actually see is this a compensated or a partially compensated respiratory acidosis. But yeah, they will have a normal or an abnormal. Typically, they'll have an abnormal CO2. Does that kind of make sense there? All right.
Now, are these, remember how we had discussed the point of treatment?
The point of care testing?
Yeah.
Uh-huh.
Do they have that for arterial blood gas?
They sure do.
Do they?
Yeah, it's one of the things you can test for. Yeah. And there are companies that, particularly companies that transport a lot of vented patients that are on ventilators, they want to see how well they're ventilating the patient and is this patient compensating well. They'll actually do ABGs during the transport and then change the ventilator settings to try to accommodate what they're finding on the arterial blood gas. What's that?
Flight.
Yeah, flight, ground critical care. Yeah,
But there's even agencies, like ambulance agencies doing this now.
some do. Yeah.
So if you're, like, say, point of contact with point of care of the patient,
Mm-hmm.
throwing my Intel, checking BGO, at least kind of gets you ballpark of where you're at. Right?
What's that?
As far as
Entitled?
figuring out whether it's respiratory, or if you have someone who's like got multiple, a patient with multiple ailments, whether
Uh-huh.
it's COPD versus, hypoglycemia.
Well, entitle is going to be tough because it can't tell you compensation, right? You can't look for compensation. You just
Like, as far as like seeing how much they're blowing on versus how, I
Yeah.
guess that's my question.
yeah, like if you have if there's some septic patient and you suspect they have a metabolic acidosis, say, and then you put them on and you initiate capnography and their CO2 is low, then you can assume that they're trying to compensate for that metabolic acidosis that they have from their septic shock. So yeah, it can push you in different directions, and end-tidal CO2 tends to go along with PA CO2, right? So the end-tidal CO2 is just the highest pressure of carbon dioxide in the exhaled gas. But is the end tidal always going to be higher or lower than the PA CO2?
Higher.
So which one's going to be higher?
Probably lower because you're getting from the direct artery.
Good. It's always going to be lower, right? And if you think about it, where is the highest, where are you going to have the highest level of carbon dioxide in your body?
Your lungs.
In your lungs? Your blood? How about the tissues?
Oh, yeah. Muscle.
Right? The tissues where all the carbon dioxide is being produced, right? Carbon dioxide is a gas. It is a kind of solute. So it is going to diffuse. Remember we talked about diffusion? And what do solutes do? They diffuse from high concentrations to low concentrations, right? So if the concentration of carbon dioxide was higher in your lungs than your blood, well, where would the CO2 diffuse?
It would diffuse.
It diffuse into your body, right? So CO2 concentration is going to be the highest in the tissues, right? And it's going to be a little lower in the blood, and then a little lower in the lungs, and then lower yet in the end tidal.
Intel can kind of give you like a tip of the iceberg.
So yeah, the end tidal is going to go up. So if your PA CO2 goes up, your end tidal will go up, but they won't match. There will be like 2 to 5 millimeter difference, right? So your PA CO2 may be 40, and your end tidal CO2 is like 37, right? So what you can do is if you have a patient, say in the hospital, like an interfacility, like you're doing an LTAC transfer, and they have an ABG, a recent ABG of that patient, and so let's say this is the ABG you get on your patient here, and then you throw that patient on waveform capnography, and you notice an end tidal CO2 of 53, right? So that tells you that there's a 2 millimeter difference. So during the transport, provided your patient's blood pressure and heart rate and either they don't change that much, right? If their end tidal CO2 happens to go to 58, that would suggest their PA CO2 is approximately about 60, right? Because there's approximately 2 millimeter difference. So you can actually use end tidal CO2 to kind of correlate those kinds of changes. You know, you're picking a patient out of the hospital, you go, okay, what's the most recent ABG? Here it is, their vital signs haven't changed too much. Okay, what's our end tidal? All right, so that's our gradient. So during transport, it can kind of help you guess what the PA CO2 might be just by looking at the end tidal CO2. So that is something that you can use as well. All right, it's already been an hour. Can you guys believe that? Okay, let's take a break.